Hi everyone, welcome to our webinar this afternoon where we will be celebrating 40 years of Australian Rotary Health research, as well as our national fundraising Lift the Lid on Mental Illness event, HAT Day. In this session, we'll be introducing you to ARH's new research focus, as well as hear from a panel of experts about children's mental health. So today with us, we have Professor Michael Sawyer from the University of Adelaide, who is a medical advisor to our board of directors. He'll be giving a small presentation about our new research focus and why it's important. We'll then move on to a panel discussion with two of our previously funded researchers, where I will be asking some questions about some of their current research around children's mental health and suicide prevention, and the importance of continuing research into these areas. On the panel, we have Dr. Lisa Mundy from the Murdoch Children's Research Institute and Dr. Nicole Hill from the Telethon Kids Institute and the University of Western Australia. In the very last part of the webinar, we will also hear from our chairman, Kevin Shadbolt, OAM, who will talk a bit about the plans for Australian Rotary Health in the future and how you can help. So for now, I guess I will pass this over to Professor Michael Sawyer, who's going to give a little presentation now.
Okay, thank you for inviting me, Jessica. I think this is the first time I've ever given a presentation in a hat, let alone a blue hat. So you're seeing something relatively unique here. Hopefully the hat won't put me off too much. So my role is to set the scene in a sense and describe why Australian Rotary Health, or ARH, is focusing particularly on younger children in the next few years. ARH has a 20-year history of supporting mental health research and also for advocating for those with mental illness. But more recently, it's become apparent that there's quite a bit of work going on with young adults or youth or with adults. But our sense is there's been much less focus on children, 0 to 12-year-olds. So we're commencing a new program that will have particular attention to this age group. And the program will commence with a symposium that will take place in March of next year, which is titled Healthy Children, Bright Futures. And the notion, of course, is that if we have healthy children, they have individual bright futures, and we have a community and a country that will be containing healthy members of society. And we'll bring together in that symposium both experienced researchers and newer researchers to seek advice about how Rotary, Australian Rotary Health, could make best use of its funding. So why focus on the mental health of young children? Over the last 20 years, recognition of the importance of good health for economic productivity has encouraged substantial research to try and identify those health conditions, those diseases, if you like, that have the greatest adverse impact on individuals, families, and communities. And to do this, the impact of different problems is compared on the basis of 3 parameters. We look at the prevalence of conditions, we look at the level of disability associated with conditions, and the cost, both in human and fiscal terms. And this work has consistently shown that on all 3 dimensions, childhood mental disorders rate extremely highly. So let's just walk through some of what we know about these disorders. Firstly, we've had 2 national mental health surveys in Australia. That is, surveys that attempt to identify reasonably accurately the prevalence of mental disorders in the community. And these have both come back saying approximately 14% of children in this younger age group have mental disorders across a year. That is, about 500,000 children have a mental disorder at some point of time through a year. Another way of thinking about that is to think that we have about 300,000 births in Australia every year. So each year we have a new cohort of 300,000 new citizens, if you like, coming into the community. Now, if we look after them, they will be healthy individuals, they'll be well educated, and they will be able to contribute to our community, and they will be well functioning in their own right. On the other hand, those data I just gave you suggest that something like 40,000 of those children will start tracking down, will start running into problems. And we do the maths of 14% and 300,000, etc. So that's a real loss to us as a community, and it's a loss to them as individuals. The other worrying thing is that we did the first survey in roughly 2000 and the second survey in roughly 2015. And the rates of mental disorders were not declining across those periods of time. So in other words, we haven't cracked how to actually reduce the prevalence of problems so that fewer of those kids coming out as a new cohort each year have problems. So that's the first point. The second point is that over that same period of time, we've begun to recognize that many of these disorders that have their onset in childhood persist. Some recurrently, like depression comes and goes, but persists through. Conduct disorder persists continuously. Turns out that something like half of all of the mental disorders across all the age groups have their onset in childhood. So ARH is thinking, how can we actually go about reducing the number of kids who track into adolescence, if you like, carrying the burden of mental disorders? Thirdly, mental and substance abuse disorders turn out to be the conditions that take away the most number of healthy years from children. So if you think about living with healthy years, we've got 100%, it would be lovely if we had 100% of kids have healthy years all the way through, but these disorders start taking away healthy years. And what you can do with the data that's been run through is to estimate, well, what are the conditions that take away the most number of years? And it turns out that mental disorders and substance abuse, particularly with parents, are the big ticket items. Again, it emphasizes the importance of trying to come to grips with how can we reduce this impact? How can we ensure that our new citizens track through childhood and arrive into adolescence and adulthood as healthy, well-educated individuals? The final thing that stood out in recent years is the financial costs. And it turns out that those financial costs are not only imposed on health services, they're also imposed on education services, on social services, and on justice. They're also imposed, of course, on individual families. So if you think that if you were a single mother who was struggling to cope and you had a child who had one of these mental disorders, such as attention deficit hyperactivity disorder or oppositional disorder, where a child might be, for example, suspended from school or struggling from school, there are huge costs that are imposed on you, not only stresses, but costs as well. How do you handle it if you've got two other children and you need your job and one is suspended from school and sent home, which tends not to be the most useful thing that happens, but it does happen. Even if you've got two parents who need to be at work, what do you do if you're losing sleep at night because you're worried about your child or your child is up and roaming around? These are big ticket issues in terms of costs. Let me give you one other quite practical example. So we conducted a couple of surveys, as I mentioned. So we had information about the mental health problems of children across Australia. We were also able to get information about education progress. So most people will know about NAPLAN scores, the notion that children undergo testing regularly through schools. We were able to bring these sets of data, huge sets of data describing mental health problems among children in the community and their education progress together. That enabled us then to compare, and I'm just picking one example here, but we could compare the progress of children with attention deficit hyperactivity disorder with their peers, with kids who didn't have mental disorders. What we found was that by year 3, children with ADHD were 9 months behind for writing and 1 year for reading. Now, these are fundamental school tools, if you like, that you need. By year 9, these kids were 4.5 years behind for writing and 2.5 years for reading. Now, once you're a year or two behind in your school progress, it's very hard to catch up. It's also very hard for schools to enable you to catch up. So you start off a trajectory that's beginning to predict quite poor outcomes later in life. In fact, if you do poorly in school, if you drop out, it predicts all sorts of things you don't actually want. You don't want to be in poverty, which it predicts. You don't want to have health problems, which it predicts. You don't want family and marital problems, which it also predicts. Again, because these conditions are common, something like ADHD, you can't achieve educational goals. We can't have a well-educated population at the level we would like if this continues. A challenge for advocates, for people like ARH, is that the recognition of the size of this problem that I'm describing to you has only been apparent in the last 20 years or so. So until the mid-90s, when we started conducting some of these large community surveys to get estimates of the problem, people thought they were minor. So the notion was, child mental disorders, this is something that was dealt with in the, the back part of the hospital, with psychiatrists, and nothing to do with me, thank you very much. This is not us. Unfortunately, it is. It turns out that, in fact, these disorders are present amongst children in all social groups, across all families in terms of income. rates are higher amongst those who are in poverty, who have very little income, but in fact the largest number turn out to be in middle class or upper class families, because there are a lot more of those families. So the absolute number of kids in problems in those groups is higher. Furthermore, these children continue to attract social stigma, and because they're more commonly experienced by families who have limited financial resources or social resources, for example, the parents may also have mental disorders, it's hard to get effective advocacy. So as a result, I think that advocacy for children with mental disorders has remained weak, despite the strong evidence that problems in the area are a major public health problem. We have a big public health problem and resources that were designed 30 or 40 years ago to manage something much smaller. These problems are not going to be managed by a few rooms in the back of the hospital, thank you very much. It's simply not possible. But governments struggle to move resources around. Every time you want to move resources from A to B, even if B has been recognised as a very big problem, all the people in A say, look, hang on, I don't want that happening to me. So it's a very big problem for governments. So what could we do? What sort of things might we have our minds on if we are supporting ARH? ARH is working at it. The first thing to recognise is addressing these problems is not done in a sprint, it's done in a marathon. So if you look at public health problems where we've had an impact, you've got to look at 5, 10, 15 years. That's not to say you don't do anything. It's to say that you get iterative improvement. You get a steady decline in rates. So look at something like, and I like motor vehicle accidents among young males or deaths among males. Look from the 80s through to the 20s. You see this steady decline. It doesn't suddenly get solved and it's all done and dusted. You've got to work at it. And the other thing is you need a team. You need government legislation. You need practitioners like police and ambulances, and you need good science. Look at any of the areas where we've had success. The one I find most useful in thinking about what we could do for mental health is the childhood cancer model. What do? They enroll all the children that they possibly can in trials. So if you go into an intensive care and oncology unit, what you find is a whole lot of kids in trials. They're in trials that are coordinated internationally, and they work away iteratively, testing new approaches to managing the illnesses. They make good use of existing data so that they use the information not only for administrative purposes, but in order to sort out how to improve care. And they ensure that as far as possible, the treatments are delivered at a high quality level. So they're not all over the place. They've got collecting their data well, they're running high quality trials, and they're actually getting outcomes that improve. Now, unfortunately, mental health services have never had those resources. So I think of mental health services struggling with this vast, great problem, tiny resources. I think of situations like in Italy when COVID first surfaced. People can't get themselves organized when they've got just a continual thrust of numbers coming at them. So we need to provide support to those services. We need to generate the new knowledge that will enable us to effectively help these children better than we've ever done before. We need to think, how can we reduce the numbers in the community? How can we help in targeted populations where people are poor or don't speak English? And how can we get more effective services running for those kids who have to get to a service? So in conclusion then, from my point of view, INSL talked about in countries of all levels of wealth and development, mental illness affects almost every aspect of society and the economy. Despite this, mental illness continues to be viewed as a problem affecting individuals and families. These are not me, thank you, these are people elsewhere, rather than as a policy challenge with significant economic and political implications. The early onset of mental disorders during childhood, their chronic course, and their broad impacts that mean that if we're going to overcome this challenge, we must focus our endeavours strongly on childhood. That's why what ARH is doing so well and is so important. If we don't, I believe we'll be too late. So that's my orientation to the session. So I'll now pass it back to Jessica, and maybe I won't have to keep my hat on too much longer. So Jessica, back to you.
Thank you, Michael. Thank you so much for talking us through, some of the issues that we're facing with children's mental health at the moment. It's such an important area, and it's something that we're going to be focusing on next year, funding research into the mental health of young Australians aged 0 to 12. So I guess now that we've sort of got an idea of the direction of ARH funding, I'll now introduce our two guests of our panel today. So here we've got Dr. Lisa Mundy, who is the project manager of the Childhood to Adolescence Transition Study, otherwise known as CATS. This is a unique longitudinal study of over 1,200 children in the middle years of school. CATS is based in metropolitan Melbourne, Victoria, and began in 2012 with the aim of improving our understanding of child health and emotional development in late childhood. Dr. Mundy has a PhD in developmental psychology. She has worked as a postdoctoral research fellow at the Centre for Adolescent Health within the Murdoch Children's Research Institute since 2011. Today with us, we also have Dr. Nicole Hill, Research Fellow in Youth Suicide Prevention at the Telethon Kids Institute and the University of Western Australia. Nicole is leading a youth suicide prevention research stream at Telethon Kids Institute with a focus on preventing the occurrence of self-harm and suicide in young people, and working with communities and stakeholders to improve equal access to healthcare services, including postvention among vulnerable Australians. Nicole was awarded her Masters in Brain and Mind Science from the University of Sydney and her PhD from the University of Melbourne. She currently holds a Prospect Research Fellowship with the Forest Research Foundation in WA. So I guess we'll just open up the questions now, and maybe at the end, if anyone does have any questions that they would like to pose to Nicole and Lisa, feel free to write any questions down in the Q&A function. But starting with Lisa, could you tell us about some of the statistics and perhaps some interesting findings in the literature in the area of children's mental health, especially for the earliest years of life?
Thanks, Jessica. Thanks for the opportunity to be here today. Well, I think Michael's taken us on a really good journey through some of those really key statistics, especially around children's mental health in these earliest years. And one of the really striking findings that has always sort of stuck with me is that 1/2 of all mental health problems, that's all mental health problems, begin by 14 years of age, which I think is really striking and really important in terms of the agenda that ARH are moving towards now. So that means that for many children, those symptoms of those emotional and behavioural problems are beginning well before 14 years of age. So they're really beginning during those early, mid and later childhood years. And unfortunately, as Michael has highlighted, for many children, these will persist throughout adolescence and into adulthood. And so it's really important that we are looking at how we can identify and support children and families during those earliest years of life. So thinking about those kind of middle, late childhood years, we've typically they've typically been pretty neglected, to be honest, as Michael's pointed out. And that's really because sort of previously we thought that children were doing pretty well during these years. We thought not much was really happening for children, that they were doing pretty okay and they were generally pretty happy. But we now understand that that's not the case, and actually that these years are a period of huge change for young people. So for example, if we think about puberty, then we might typically be thinking about puberty happening for children around sort of 12 years of age, which is when we see the physical changes that are happening. But actually those biological changes of puberty are now happening, we now understand are happening much earlier. And so the first hormonal changes are happening at around 8 years of age, with some massive hormonal changes happening during these years, which are driving brain changes that happen as well. So really, those brain changes are happening all the way from those earliest years of life and all the way through these middle and childhood years as well. And with that, that's really driving the way that children connect with their external world. So these years are really important in terms of a child working out where they're fitting in the world as well. So even at 8 years of age, a child's starting to work out what's important to them, where they fit in the world. That peers become really important, and with that obviously peer relationships, and so we start to see more bullying happening around these years as well, which is obviously linked with mental health problems. And also it's when children are starting to sort of move away from the family unit, and sort of thinking about how they fit in the wider world as well, and how they're doing within school starts to become really important. They're starting to work out whether the school is the place for them. And so, as Michael was saying, when these children have got problems that mean that they're starting to fall behind in school, then that then that becomes a place that's not necessarily a happy place for children, and that really compounds as they continue to move through school. So really addressing these problems early on is really, really important. And so we recognise that these years are a period of opportunity. There's lots of good happening, but they are also now, we recognise, a period of risk where many of these mental health problems are starting to emerge. And so this really highlights the importance of intervening during these earliest years, when these symptoms of emotional and behavioural problems, mental health problems are starting to emerge, so that we can give children, their families and broader community the best possible start to life.
Yeah, great. Well, thank you for answering that question. I might hand over to Nicole now. So some of your research involves looking at self-harm and suicide in young people. What do we know about self-harm and suicide in this younger 0 to 12 age group? And is there perhaps any difference in younger children versus adolescents?
Yeah, so I think when we look at suicide and self-harm across the board in young people, we can see that it's the leading cause of death. And so that means that when we look at other causes of death, whether it's accidents or other childhood illnesses, suicide will account for the largest proportion of those deaths. And we typically look at those ages from 10 and above, and that's mainly because statistics around suicide simply isn't available in those younger groups, because there's a lot of, I guess, caveats around intent and whether a child below the age of 10 is aware of the intention in which we would typically use to establish a suicide. So it's a little bit complex in that regard. But what we see, and especially with the engagement I've had with schools and who are obviously the primary point of contact for young people within this population, is we've got young people that are in distress beginning at earlier and earlier ages. Here in Western Australia, I'm working with the Department of Education, and they've got self-harming behaviours occurring in grades 4 and above. And so what we can see is that we've got young people that are in distress, they're reaching out for help and are demonstrating these behaviours externally at an earlier and earlier age. And when we look at when young people are provided with education around mental health, they're really not receiving that until they're in much higher grades in high school, for example. And so one of the key things I would argue around suicide and self-harm prevention is that we ought to be putting that in place at much earlier ages within the developmental process. At the end of the day, young people are experts in their own lives, and there really isn't a strong rationale for waiting until they're 14 years old to receive education around suicide prevention and self-harm behaviours. In terms of whether there's a difference between young people and adolescents from 14 and above, we definitely see in the suicide statistics a dramatic increase once we get to 16 and above. It's really quite rare for a young person during childhood to die by suicide, but we are seeing those numbers increase substantially over the last 10 years, where we've now got young people as young as 10 years old that are dying by suicide here in Australia. And so it's a significant public health problem. Young males are more likely to die by suicide at a much higher rate than females. So they represent about 75% of those deaths. And we see that across both age groups, that younger cohort and the older one. And when it comes to self-harm behaviours, we almost see a reverse gender paradox, we call it, where females are more likely to self-harm during that age group. And so in terms of preventing, self-harm is a significant predictor of later death by suicide. So if a young person is engaging in self-harm, that really represents a critical opportunity for intervention. And some of the key things that we can look at to do that involves upskilling parents and friends and other young people to recognise those signs, and also to equip them with the skill set to safely communicate about suicide and self-harm, and equip them with the tools to reach out for help as well.
Yeah, thank you for that. And I have noticed that a question has come up in the Q&A section, and I think you sort of touched on that. I'll just read the question out again. So I'd like to ask about the issue of self-harm amongst young children. What sort of work has been done in terms of prevention? and if there is any research on the topic at the moment. So you did sort of touch on that area just then. Is there anything else that you can sort of elaborate on to answer this question?
Yeah, and so when it comes to self-harm behaviours, it's a very complex area because there's no single cause of self-harm. And certainly from the literature that does exist, we can see that mental health does play a big role in that, but also the help-seeking behaviour and support that's around a young person can also play a pivotal role in those behaviours. And the other work is centres around those more psychosocial factors. So these are things like education and residing in economically disadvantaged regions where there's reduced access to healthcare services, for example. These are also factors. And so really when it comes to what evidence is there around self-harm in younger cohorts, it's certainly available. I guess the critical thing is identifying for each individual what those precipitating factors are. And at the end of the day, we need large studies to inform how we can ultimately tailor responses to each individual.
Okay, so I guess moving back to Lisa, do you have maybe some tips for parents or anyone who is in contact with young children who might be experiencing some mental health difficulties?
Yeah, well, I think just in terms of thinking about the signs that you might notice in your child that might give you an indication that they might be experiencing mental health problems. So there might be things like sort of more obviously like being unhappy, feeling down, being afraid, or particularly worried. But there can be some other more subtle things like having trouble sleeping, or perhaps having trouble eating, avoiding things that they might usually enjoy doing, like catching up with friends, going to parties, that sort of thing. They might be avoiding going to school is another thing. Some children might be acting out more, so you might find that they have more aggressive behaviour, having tantrums, that sort of thing. Some children might have difficulty paying attention suddenly, and that's a change from what you've seen before. Other children might also sort of regress or kind of go back in things that they sort of developmentally have been able to do, and suddenly they kind of go back to doing. So things like bedwetting, that you might start noticing that your child, starts wetting the bed again, and that's unusual. And some children also report physical pain as well. So they might be saying that they've got more tummy aches or headaches, those sorts of things as well. And that can be a sign that they're having sort of more emotional or behavioural problems as well. So those are all things to look out for that might indicate that a child, either your child or a child that you know is having difficulties at the moment. In terms of what you can do, I think the first thing is talk to your child, and importantly, listen to your child as well, hear what they have to say, let them know, ask them how they're feeling, and let them know that you understand and that you're going to try and help them as well. Now, for some children, they'll sort of bounce in and out of these feelings, but if it persists for more than a few weeks, then that's when you really do need to seek professional help. And so for many people, the best person to speak to might be a GP. If you're worried, you could also speak to your child's teacher, and they can help sort of point you in the direction of people who can help you. And then your GP might refer you on to a psychologist, or the teacher might connect you with a school counsellor. And also, if you're sort of at home and not sure what to do, then another good helpline can be or a good helpline rather could be the kids helpline as well. So children over 5 can speak to a counsellor on the kids helpline as well, and that can be a good way of just starting the conversation. And I guess the other thing I'd say is that for parents who do have children who have got mental health problems, that can be really trying and a really difficult time for parents as well. So it's also really important to think about your well-being and your mental health during that time as well, and reach out for help if you need to as well. So there's parenting helplines and your GP as well.
Yeah, thanks for that, Lisa. I'm sure that's very helpful for parents. And I guess just adding on to that, Nicole, what are some of the signs that we should be looking out for in young people who might even be thinking about hurting themselves or perhaps ending their own life?
Yeah, so the research that I've done in suicide prevention space in young people has shown that 1 in 3 young people who have died by suicide has communicated to someone, whether it be a friend or peer or a parent or other person in their life, of their intent to die by suicide. And so I think one of the critical ingredients to suicide prevention in this age group is then first reducing the stigma around suicide, self-harm and mental health, so that when someone does disclose distress, that they're not met with an adverse or negative reaction. Because we know that young people who disclose distressing information for the first time, that initial reaction can really set a pathway for future help-seeking behaviour. And if that reaction is negative, they're less likely to then seek help in the future. And so what you can then imagine is almost a snowballing effect, where they're in distress, they've reached out for help, they've got a negative reaction, so they didn't receive help, and then that issue can then continue to grow and become a much more burdensome problem to that individual. So I think raising awareness around mental health is one of the most critical ingredients. I think reducing stigma, and not just then having more acceptance of mental health and awareness in the community, but actually having the services available for young people to then seek support, and also equipping with friends and peers and parents with information on where to direct them to help if they are in distress. So being aware about things like headspace centres, being able to attend your GP and have those conversations about mental health and wellbeing is a really important ingredient for self-harm and suicide prevention in that age group. In terms of other warning signs, so I think one of the first and foremost is that they do communicate their distress, and then being able to respond to that. I hear a lot of concern from parents and others in the community about the role of social media in young people's lives, and that is often one of those platforms where people can see signs and warning signs around certain behaviours. One of the things I would recommend there is to have that conversation with young people in your lives around whether social media is a harmful or helpful thing within their lives. At the end of the day, they're the experts. So being able to have that frank conversation around, their behaviours, if they are reaching out for help or communicating distress in these environments, is it actually helping them or harming them? So that's one of the other ingredients. Like I said before, self-harm and suicide, the factors and warning signs behind them are quite complex. But at the end of the day, if you are concerned and you are seeing any behaviours that look or are different to what you typically see, have a discussion with that young person. Asking about suicide and asking whether someone is in distress is not going to cause them to then enact on that. It's going to be helpful. And so really raising awareness about that is critical in this space.
Yeah, absolutely. Yeah, so many good points there, Nicole. So yeah, thank you to both of you for some of those tips. We do have some other questions that have come up through the chat. So I might just read them out and kind of, open them up to anyone who wants to answer. So I guess one that we've got here from Warwick is, are parental resistance or denial significant factors in raising interventions in early childhood mental health? Anyone want to answer that?
Michael, are you going in?
Yeah, I'll make a comment then. The two surveys that were done, the two national mental health surveys, came back with very consistent information about factors that make it difficult for parents to get help. And interestingly, both of them said, or parents in both of them, said that the critical issues were practical issues. So the thing that was difficult for parents was the services were too far away. They didn't know how to get services. When they did get to services, they found waiting lists were too long, and the expense was too great for them. So there was a very consistent element of what makes it difficult. So in other areas, things like stigma, for example, was mentioned. It was mentioned a little more by adolescents reporting directly on themselves, but the dominant issue was we just don't know where to get services, or they're too far away for us to access. So that's what came back in the surveys.
Yeah, great. We've got another question here as well from Nina. How has the pandemic affected young children? And is it already possible to see the negative impact on them?
I can certainly speak about that from a suicide prevention standpoint. What we've seen in terms of hospital presentations for self-harm and suicidal ideation, that those have anecdotally, although I believe data is about to be released on this quite publicly very soon from the ABS, where we've seen an increase in those presentations to hospitals. What we've seen a decrease in, however, in Australia since the beginning of the COVID pandemic is a decrease in suicide deaths. And that's been across the board. We don't quite know how to explain that yet, as these data have only just been released, but what we can see is that although deaths have decreased, we've seen a significant increase in the demand on hospital systems and police, first responder call outs, such as ambulances for mental health crises in young people.
Okay, and we've just got one more here, and then we'll go back to the other questions. Also, what to do when parents refuse to look for help for their children because of the stigma or labelling the children's mental health issue?
Yeah, that's tricky, I think. Is this a question in terms of if you're aware of another child? I think speaking to someone, if it's a child themselves who's aware that they've got problems and their parents not sort of supporting them, then I think a really good place to speak, is school. So a really good person would be to speak to a teacher or a trusted person at school, and usually then they can help either kind of navigate that conversation with the parent or help steer them towards the right support. So that's what I'd be suggesting if the parent's not willing to make that first step.
Yeah, we also see in the suicide prevention space a lot of research that's been done looking at young people's help-seeking behaviour, and we see from that literature that young people are more likely to disclose their distress to their peers and friends rather than an adult in their lives. So I suppose we can almost leverage that in a situation where a young person doesn't have the support from their parent figures. Then how can we upskill other young people in their lives so that they do have a strong support network? And there's certainly a bit of literature and research being done internationally that's looking at creating these almost herd immunity or networks of mental well-being around school-aged peers within school settings, so that they're getting that wraparound support elsewhere.
One of the challenges in the area is looking at what children who are depressed do. And is that the same as all children? So one of the studies we did a little while ago was and we were able to do it because we could stratify it, we could divide children up into those who said we've got very few problems, those who said we've got moderate problems, and those who said we've got a high number of problems. And we then looked to see, did the children in each of those groups, or the young adolescents in each of those groups, do the same thing? And what it turned out was that those who had the highest, who were the healthiest, would all say, yes, we would go to our peers and we would go to our family. But what was quite striking was that those who had the highest level of depression said something very different. They first of all said that they told us that far fewer of them would actually go to peers. They also would less often go to parents. And what was really quite frightening was a very large number said we would do nothing. So the pattern of what would happen amongst those kids was quite different. And of course, as soon as we saw it, we realized, well, of course, many of these kids who, for example, have thinking of suicide or who are feeling depressed don't have friends, they don't have peers, or they've been subject to bullying. So they're much more reluctant to go to peers than other kids would tell you they would do in the same circumstances. Or their parents might have mental health problems, or they might be fighting. So I think one of the challenges is to make peers or help peers know how to reach out for these children, because many of them won't initiate help themselves. They won't initiate help with parents, and they won't initiate help with peers, in part because a number of them don't have kids or peers who they think are friends and supporters. So it's quite important not only to target the children with problems in these areas, but to think hard about what can we do to enable their peers to feel more confident in terms of what they can do to help. And there are a lot of programs around mental health first aid that are very good in terms of giving advice about what to do, but remaining passive is not a good idea.
Yeah, absolutely. Some really good points there, Michael. I guess now, Lisa, how can new research in the field of children's mental health improve mental health outcomes for children?
Yeah, thanks, Jessica. This is a really important question. And I think, as we've been hearing, there's really been a really big focus, particularly in Australia, but probably internationally, really in terms of our investment and policy focus really on existing mental health problems in young people and adolescents. And obviously that's really, really important. So treating young people who have got problems and treating adults who have got mental health problems is obviously, you know, critically important. But what that kind of focus has done is it's meant that we haven't had the same focus on these earlier years and really helping to identify preventative interventions that we can make to support children before they start developing those earliest emotional and behavioral problems, and also, you know, for those earliest mental health problems that have actually emerged during those childhood years as well. So we really need to be putting much more research focus onto identifying and supporting children and their families during those earliest years of life. So that's just part of some of the work I've been doing at the Murdoch Children's Research Institute with the CAT study that you mentioned at the beginning, has really been trying to identify which children are at risk of developing and maintaining or developing or maintaining mental health problems in that transition from childhood into adolescence, which children manage that transition well, and then really trying to think about which factors we could intervene to try and give children the best possible start to life, which is obviously what we really want to be doing. So, for example, one of the things that we've identified is as being a really big risk factor is that transition from primary to secondary school. So in sort of policy focus and the research work that we've done, both in Australia and internationally, there's been a lot of focus on supporting children move or adolescents move from high school and the pathways into further education or work. We've also put a big focus on getting children into primary school, which is really good. And so we've seen some positive outcomes in those earliest years. But going back to my earlier point, we've typically thought that, you know, those kind of middle years were mid years were kind of going pretty well for children. And so we didn't put the same attention on that transition from primary to secondary school. And what we've seen in our work is that children who don't manage that transition well are over 3 times more likely to have depression and anxiety in secondary school. So that's, you know, a really, really huge risk that's happening across those kind of later primary school years. So really in our work at the moment, what we're trying to do is to develop an intervention around how we can be supporting children during those mid and late primary school years, because that transition isn't just, you know, at the end of year 6, you know, when children are kind of 12 moving from primary to secondary school, but really it needs to be thought of as a journey, and we need to be equipping children with those social and emotional skills much earlier in life. And I think that comes back to some of the points that Nicole and Michael have been making as well, and in terms of the importance of schools, in terms of being able to support children develop these emotional social skills that set them up really well to be able to support their own well-being and also those of their peers around them. So children spend over half of their waking hours in school, so it's a good place to be thinking about how we can be improving well-being during those primary school years, I think.
Yeah, absolutely. And that's one of the areas that ARH is focusing on at the moment, Lift the Lid in schools. So yeah, some really good points there. I guess, Nicole, what more can research add to our knowledge regarding self-harm and suicide in children?
Yeah, look, I think research is really the fundamental cornerstone of informing best practice and in implementing effective suicide prevention. At the end of the day, if we want to see a measurable decline in those numbers, then it needs to be informed by good quality research. And as Michael said earlier on, this needs to be research that's conducted or with the mindset that it's a marathon, not a race. And with that comes the fact that we need large and longitudinal studies to really look at how mental health and high-risk behaviours evolve over time, especially during what is a very dynamic developmental period for young people. We see such different variations and trajectories of behaviours, and we need to be able to capture that both from a mental health perspective, but also the psychosocial and social determinants that contribute to these high-risk behaviours. So that's one of the first, I guess, key areas that research can contribute, is that large, high-quality studies that take that long-term approach. The other thing I would say is one of the, I guess, critical ingredients that research can contribute is taking on board both the lived experience of people who have experienced suicide, self-harm and mental health distress. And that's also including young people and their parents. Because I think at the end of the day, these are the individuals that are able to point us in the direction for where research should be focused, because they are the ones that have experienced that. Another key area is actually speaking with the stakeholders on the ground who are delivering mental health services to young people. We're in a system right now where, as Michael said, we've got incredibly long wait list times. We've got a lot of people reaching out for help. What can we do to equip service providers and change the system level factors that also contribute to the high rates of self-harm and suicide in the community?
Yeah, great. Well, thank you so much to both of you for answering our questions today. We've just got one more question that's come through the Q&A. So again, I'll just open this up to anyone who wants to answer it. This one says, what do you do if a child refuses to interact with counsellors or psychologists?
I can just quickly chime in on this one from a self-harm and suicidal behaviour standpoint. It's a very challenging situation, but at the if a young person is at significant risk of suicide, there are safety measures in place within the mental health service sector where that decisions can be made where an individual or a healthcare provider can step in and then have that young person assessed. If the young, sorry, I've got a car going on in the background there that interfered for a second. That's often the last resort. If we have a young person that is in significant distress, we ultimately want to have them on board in seeking treatment and engaging in that process. But the healthcare service system is set up to provide, I guess, a safety net for those very high risk behaviours.
Yeah, great. Did anyone want to add on to that at all?
Well, we live in a free society, don't we? So we have that advantage of considerable freedoms, including freedom to make a lot of decisions about our health and our health care from a relatively young age. I mean, the reality is when I would see children who were 10 or 11 years old, if they were determined not to cooperate, I had to indicate to them that, their parents would be able to get them along to appointments for a little while. But at the end of the day, even at that age, somebody could make it impossible to provide care. And they have to think kind of hard about the benefits and risks of not participating. But as was pointed out, that then requires a judgment by the parent and by a clinician as to, has this crossed the line? Has this sort of reached the point where freedom of choice is going to be restricted because we consider a child at real risk for harming themselves, and we're not prepared as a society to allow that to just happen without any form of intervention as well. So those are difficult decisions for parents to make, and they're difficult decisions for clinicians to make. For parents, I think the greatest value is to seek advice from others, seek advice from teachers, seek advice from other parents, think hard about where the situation is and how aggressively you want to intervene. Don't try and make the decision alone. Seek out help. And that, of course, is difficult if you're an isolated parent or you're a single parent who doesn't have peers to turn to. And that's where opening up things like telephone helplines, by encouraging contact with general practitioners so that you can share the burden of trying to make, what's in fact a very difficult decision. I mean, they would be my comments.
Yeah, great. And was there anything else that either you, Nicole, or Lisa wanted to add about the topic of children's mental health or self-harm and suicide in children today that we haven't already covered?
No, I think it's been a pretty good discussion. It's been great to be part of it. I guess I just want to kind of really say how great I think it is, this new approach that ARH are taking in this space, and just really to thank them for their continued support and funding in this space, and all the supporters as well. So thank you.
Yeah, look, I can second that. I think the discussion's been fantastic, and really appreciate that ARH is putting a focus on youth mental health, particularly in those younger age groups. It's great.
Yeah, well, thank you so much again for joining the panel and our webinar today. It's been really, it has been a really interesting discussion, and I hope the people watching can take a lot out of this. I guess now just to wrap up, I'd like to hand this over now to our chairman, Kevin Shadbolt, to talk about how you might be able to support this new research focus that ARH is focusing on. So yeah, over to you, Kevin.
Well, thank you very much, Jessica. I'm very pleased to be involved in this webinar today with our researchers, Nicole and Lisa, and of course our board member, Professor Michael Sawyer. I think the comments have been particularly interesting, and I've been very impressed with the way that each of the participants have been able to step forward with some very, very useful and very interesting comments. And I think too endorsing the research that we're approaching in the coming year. But today is a very important day as we join people around the world to create awareness of mental health. At Australian Rotary Health, we mark this occasion by celebrating Hat Day. We all have a hat on today. We invite everyone to wear a hat, any kind of hat, as you can see we have today, and help us lift the lid on mental illness. So any donations to mental health research are always welcome. Here in Australia, we have some serious mental health issues. We know that 1 in 3 people suffer a mental illness by age 25. We know that 50% of the population will experience a mental illness in their lifetime. And it is reported that since COVID lockdowns, anxiety and depression in our young has increased significantly. Australian Rotary Health celebrates its 40th anniversary this year. It was established to fund medical research in Australia, and the first research project was that of SIDS. As a direct result of that research, the incidence of SIDS was reduced by 80%. In the year 2000, Australian Rotary Health focused its research on mental health. At the end of last year, we funded and managed 40 mental health research projects and jointly funded 53 projects in the general health, all projects running for a period of 3 years. ARH also provides 80 Indigenous scholarships to assist people from remote areas of Australia to obtain qualifications in the field of health and medicine. We also provide a limited number of scholarships for trainee doctors and nurses to spend a year working in a rural community. I'll just touch on some of the highlights, if I could, such as mental health first aid, a training program to teach people to identify a person's experience of mental health crisis and how they might assist. This is now taught in 25 countries around the world. Teen mental health first aid is available for schools, and Lady Gaga uses teen mental health first aid in her extensive youth programs in the United States. Another, the Cool Kids program, helps children experiencing severe anxiety and depression. It is used in over 30 countries and is now helping an estimated 10,000 young people each year. Other research examples include establishing a link between junk food and depression, positive parenting strategies, and studies done on post-traumatic stress disorder. For a number of years, Australian Rotary Health mental health research has been concentrated on the under 25 age group. And as we've heard today, in the coming years, research will focus on the 0 to 12-year-olds. This is a significant change. And I think from the comments of our 3 speakers today, they are endorsing this change. We're advised that 50% of adults who experience mental illness, show symptoms by the age of 14. It is thought that if we can intervene at this young age, we may be able to reduce and even prevent mental illness in later life. Australian Rotary Health is limited to the amount of funds available. We are funded by Rotary clubs, members of the public, and from bequests. Every cent donated to Australian Rotary Health goes to medical research. Donations can be made online to our website, australianrotaryhealth.org.au, and any donation over $2 is tax deductible. So we invite you to join us and support the research that we are undertaking and help us lift the lid on mental illness. Thanks, Jessica.
Well, thank you, Kevin, and thanks again to Lisa and Nicole and Michael for joining the webinar and having such an interesting discussion on children's mental health. And today on World Mental Health Day, anyone who has watched this webinar, we do encourage that you head to our website, australianrotaryhealth.org.au, to make a donation if you can. So thank you very much, and I hope you all enjoy the rest of your afternoon.